Begin. Hello. Is this good? Okay. All right. So my name is Marc Landsman. I'm one of the third-year GI fellows. I'll thank you to David for inviting me to come and chat with you guys about GI bleeding. The goal today will be to sort of talk to you about how like a GI fellow approaches GI bleeding. GI bleeding in general is a pretty vast topic. You can do your own lecture on upper, small bowel, and lower. So I'm going to try to squish everything in to make it pertinent from a nuts and bolts perspective of what I think an intern should know, and then also hopefully some good things for second, third year. So my objectives today are to define gastrointestinal bleeding for appropriate triage, review gastrointestinal bleeding sources, so for upper, lower, and small bowel sources, identify key steps in initial management, including resuscitation and, importantly, triage, and then we'll talk about medical management of gastrointestinal bleeding. So I think it's important to define gastrointestinal bleeding. Oftentimes, as fellows, we see, is this it's just GI bleed. It's not, overt bleeding. It's not occult bleeding. So I think the occult versus overt bleeding, and then active versus inactive bleeding are topics I'm going to harp on a little bit early in this lecture. So defining the problem guides management and triage. So it can tell you should the patient go before, should they go to step down, should they go to ICU, and then it also helps with informing the urgency of endoscopy. So hopefully if you see what we see as urgent, you'll have an idea of where the patient needs to go, and then also how quickly you need to act. So overt bleeding, so this is visible to the naked eye, and remember that blood is a cathartic, so no one's going to present with anemia first and overt bleeding later. So you're going to see the anemia after the equilibration process. So you're going to see the blood. Overt bleeding includes hematemesis, which is bright red blood and clots, and I'll show you guys pictures in a minute. Coffee ground emesis, which literally looks like coffee grounds. And then melena is black and tarry, and I think that especially with communication from the ER, from the nurses, you guys hear melena, but I think especially with the, with not you guys, but with like the nursing staff, like you'll hear, they tell you melena, and then it's actually not melena. So I think it's important to know that melena is black, but it's also tarry. And you'll see melena with as little as 50 cc's of blood. So if you have a tiny 0.1, 0.2 gram drop in hemoglobin, you'll see melena. So if you don't see that, and you're trying to explain anemia, that's an acute anemia, it's going to be difficult to explain that if you don't see the melena. And again, it's not brown, it's not dark. We hear a lot of dark. It's not maroon, it's not dark green, brown, it's not pellets or hard. It's going to be black and tarry. And then hematochezia is red or maroon, and that's with or without clots. So, so that's overt bleeding. Occult bleeding is defined as either iron deficiency anemia or a positive fecal occult blood test. And the FOBT is a test that should be an outpatient test. I know it happens a lot inpatient, but you get a lot of false positives if it's done on the inpatient side. Occult GI bleeding is generally a non-urgent workup, and it's oftentimes reasonable to do it as an outpatient. The caveat to that being if the patient is inpatient and requires blood transfusions for their anemia, then you might do an inpatient workup. So here's a picture of the overt bleeding. Melena is the top left. The top left. Notice how it's tarry. I know it's lunchtime. I didn't think about that, but hematemesis is on the top right, so it just looks frankly bloody. It won't be a question. It'll look like blood. And then coffee grounds will just look like liquidy coffee grounds. Anything else really is not true, like overt bleeding. So tan or brown vomit, that can just be stomach contents that have been cleared. But if it looks like coffee grounds, that's when you think they're bleeding. And then hematochezia is just frankly blood with clots as well, just coming from the other end. And then, like I said, any other appearance, it's not overt or active GI bleeding. So if you don't see these things or the staff doesn't see it down in the ER, they're not actively bleeding, we'll say, at that time. So I think the history taking is important to define what active and urgent GI bleeding is. Specifically, active bleeding versus a history of GI bleeding, because then you can sort of triage them differently. So what I would say is step one, you ask the ER, you ask the nurses if they've observed any bleeding in-house. Step two, you perform a rectal exam. And they, like I said, the exam does not mean the stool card. It's generally just what's on your finger. So if there's nothing on your finger, then there's no overt bleeding evidence on the physical exam. Obviously, unless that it's been observed from the other end vomiting. And step three, you want to quantify the amount of bleeding, because this is also important for triage. So you want to measure the hematemesis, coffee ground emesis, melena since the presentation, and then also quantify it at home. Is it a teaspoon? Is it a cupful? Is it a bagful? And if it's hematemesis, you want to know how much. So is it just streaks of blood, or is it frankly bloody emesis? Because if it's just streaks of blood, they're otherwise hemodynamically stable. That patient could probably go to the floor, probably not going to be urgent. If you call us at 2 in the morning, we're not going to come rushing in for a couple of streaks of blood. And again, they can go to the floor. And so after that, you can make your overall assessment. Is this a high volume bleed? That's more urgent and they need a higher level of care. Or is it a low volume bleed? Is it non-urgent? Is this a history of bleeds? They're not actively bleeding. That would also be non-urgent. So this is sort of sums it up. So if you have overt, actively observed bleeding in-house, you triage to step down or ICU. That's what we would always recommend. If there's concurrent hypotension or shock with an active bleed, or they're vomiting significant amounts where you're fearing their airway may be at risk, they should go to the ICU. And then, like I said, if you have a history of GI bleed that's not observed, there's no hypertension, no shock, those patients can sit on the floor. Other triage situations that we see pretty commonly, I think I wanted to review. If you have an occult bleed, so FOBT positive stool or iron deficiency anemia, and they're requiring transfusion, they go to the floor. Occult bleed without transfusion requirement. Those are generally ones that you can say, well, we'll just have them see GI and follow up. Or if they have scant hematochezia, a stable hemoglobin, those can be referred also as an outpatient, because they're not going to keep this patient in the hospital, and it's not urgent to find the source unless they're requiring transfusions. So now you've defined overt versus occult bleeding. You've assessed the volume and whether or not the bleed is active or inactive. And now we want to move on to localization and then of the bleed and then medical management. So with upper GI bleeding, so the definition of that is proximal, any bleeding where the source is proximal to the ligament of Treitz, which is usually around the transition point between the duodenum and the jejunum. It will present with overt bleeding, potentially hematemesis, coffee ground emesis, like I said, or melena, but the only other addition is you'll see red blood that can come out of an NG tube. And then 90% of the time with melena, the source is going to be proximal to the ligament of Treitz. So that's why we always look with an upper endoscopy first. The caveat for hematochezia is it's generally lower bleeding unless you have hemodynamic instability. So positive orthostats with hematochezia or just frank hypotension or tachycardia. That's when we would suspect a very brisk upper GI bleed. So we would treat those as an upper. Some common etiologies of upper GI bleeding. So this is from most common to less common. Gastric and duodenal ulcers. Those are about, it used to be, I think, 30 years ago before PPIs or whenever PPIs were invented, were 50% of the etiology, or 50% of the time, but now it's down to 15 to 20% of the time. And risk factors are NSAIDs and H. pylori. Varices is the second most common. And you suspect those in anyone with a history of cirrhosis. And whenever you suspect a variceal bleed, they're always going to present with overt active bleeding. So like a small volume bleed is not consistent with a variceal bleed presentation. That's one where we get nervous. That's probably the most life-threatening of the bleeds that we see. Severe or erosive esophagitis, which can be suspected in somebody with a history of chronic uncontrolled heartburn. And that often presents as coffee ground emesis, where you have like some oozing from the esophagus. They get nauseous because of their heartburn and the blood, and then they vomit. These older coffee grounds, so it's less severe usually. You can get severe or erosive gastritis or duodenitis. Also, these patients will have a history of cirrhosis. Angiodysplasia, also known as AVMs. Risk factors for angiodysplasia-related bleeding or AVM-related bleeding include CKD, being on blood thinners, cirrhosis, and then outflow obstruction, basically aortic stenosis. If you have that concurrently with AVMs, that's called Hayes syndrome. Mass lesions, so polyps and cancers are also pretty common. And then Mallory-Weiss syndrome or Mallory-Weiss tears after a significant amount of retching. And then no lesion can be identified in up to 10 to 15% of patients. Some other uncommon etiologies for upper GI bleeding include a dulifoil lesion, which is submucosal artery that erodes through the mucosa and bleeds. It's usually in the stomach, and they're usually very brisk bleeding. Gastric antrovascular ectasia, or GAVE, which is basically abnormal blood vessels that are sort of in the antrum of the stomach. And those generally present with iron deficiency anemia, or can rarely present with an overt bleed, but usually not as severe. Hemophilia, for whatever reason, after a liver biopsy or an eroding mass, where you'll have bleeding into the bile duct. And when you do the upper endoscopy, you see the blood coming from the ampulla, which is the duodenum. Hemosuccus pancreaticus, so that's bleeding into the pancreatic duct, often from a pseudoaneurysm, potentially from acute pancreatitis. Those are very severe because they're often arterial, but they're all very rare. And then aorta enteric fistula, these patients generally have a history of AAA repair or a severe AAA, and those will present with Harrow bleeding, so smaller bleeds of melena, and then one catastrophic bleed. So it's good to obviously catch those early. But again, they're very rare. We've seen one in the last 3 years. Cameron lesions are ulcers that can occur in the hiatal hernia sac, and then ectopic varices, and then iatrogenic bleeding after endoscopic intervention like biopsies or polypectomies. Here's some pictures. These are all ulcer pictures, so the most common thing we see. So in the top left, you can see a arterial lesion. These are all Forrest classifications, which confer a mortality up to 10% in the Forrest 1A and 1B lesions. But I think this is just so you guys can see some of the things that we see. So a spurting lesion on the top left. In the middle is oozing from the ulcer base. The vessel that you can see on the top right there, we would clip that. Adherent clot, and then little black spots, and Forrest 3 lesions, which are just clean ulcer bases. But these are all stigmata that this is probably your source of bleeding. If you see this reported in the note and the note doesn't say specifically this is the etiology, but it generally is when you see a large enough or an ulcer. So here's a picture after we've injected it with epinephrine, and then we've clipped it, which prevents the risk of rebleeding from as high as 100% or 50% in a stopped bleed to less than 20%. Here's a picture on the left here of spurting varices. As you can see, that looks like a lot of blood. It's like a fire hose compared to what we often see. And then on the right is after we've banded it. This right here is the esophagus. It's a picture of severe erosive esophagitis, and you can see at the bottom right a little bit of oozing. And we treat that with PPI. This is what I was talking about with secondary to portal hypertension. You get mosaic pattern of erythema, that is the blood vessels sort of being pushed to the mucosal edge, and then you get local ischemia, and these can bleed into the stomach. And then this is an AVM, which is just telangiectasia, malformed blood vessel, and then this is the probe that is going to be zapping it with cautery. And then I think this is the last picture of the upper, and this is a tear after a lot of retching. This is the GE junction, and so this is a Mallory Weiss tear. You can treat that with a clip. Oh, and then gastric mass, not uncommon, previously very difficult to treat. We do have a new temporizing measure called hemospray. It's a mineral powder that we can spray and temporize these lesions that we should be getting in the next few weeks to a month or so, and it would be a good bridge for therapy to any definitive management like chemo, radiation, or surgery. And here's the bleeding lesion on the left, and then on the right you can see the hemospray applied and hemostasis achieved. So that's what we hope to be able to do soon. So etiologies of common small bowel bleeding are broken up by age. So patients that are less than 40, the most common causes are IBD, duodenal lesions, neoplasia, Meckel diverticulum, and polyposis syndrome, whereas those greater than 40, and that's the more common, I think, patient presentation we'll see in this hospital. AVMs or angioectasias, duodenal lesions, neoplasia, and NSAID ulcers are the most common. And finally, lower bleeding, lower GI bleeding etiologies, so diverticulosis, angiodysplasia, aka AVMs, hemorrhoidal, those are all painless hematochezia causes, ischemic colitis, which would present with pain, and then post-biopsy polypectomy or radiation-induced telangiectasia, which is like radiation colitis. Inflammatory lesions include infectious, IBD, and ulcers, and then neoplasia is very common too, with a large polyp with an ulceration or carcinoma. So, initial resuscitation, I think this is the most important thing. This is the thing that will save someone's life. It's usually not the endoscopy, it's the resuscitation. So it's the most important first step in addition to your assessment of their active bleeding. So you confirm their active bleed, and then you always want to remember your ABCs. Airway, breathing, and circulation. So for the airway, you can supplement them. All patients who are actively bleeding, we recommend supplemental oxygen by nasal cannula, and then if there's a high volume bleed, consideration for intubation to protect their airway. All patients should be NPO, and then you want to ensure 2 large bore IVs, 16 gauge or larger. I know that's probably reviewed for most of you. Patients with tachycardia or hypotension should be resuscitated with either normal saline or lactated ringers to achieve normotension and resolve their tachycardia. I think it's important after the initial resuscitation attempt, so 1 liter or 2 liters fluid bolus, that we repeat the blood pressure immediately after, and I think that's something that's important to follow up on because you can see if they're fluid responsive. If they're not fluid responsive, their blood pressure is still high, or they're low, or they're still tachycardic. You would consider a repeat bolus early to avoid. It's basically the same as sepsis, so early resuscitation is key. And if there's no response after a couple of attempts, you consider pressors. And if there is improvement, that's when you can start maintenance fluids and then monitor every 10 to 15 minutes to make sure that you're at the right rate. Patients presenting with upper GI bleeding should have a type and cross. And then in terms of blood transfusion goals, the goal that we generally recommend is based on, I think, pretty reasonable amount of recent data suggesting that a restricted blood transfusion strategy of a goal of 7 is associated with lower mortality, or 9 if you have severe cardiovascular comorbidities or unstable CAD. And then you want to consider other blood products, platelets, FFP, 3 or 4 factor PCC, or prothrombin complex concentrate, which I'll talk about later. I think the important caveat is if the patient is actively bleeding and they're hemodynamically unstable from it and you have the blood available, regardless of their hemoglobin, because they're hemodynamically compromised, the treatment will be to replace what is lost, so blood. That 7 is more for slower bleeding or after the initial hemostasis is achieved. Some data, so to talk about the restrictive transfusion, to inform our restrictive transfusion strategy. There's a nice meta-analysis of acute upper GI bleeding studies. It looked at 1,965 total patients, and patients that had a restrictive transfusion strategy of a hemoglobin goal of 7 were at lower risk of mortality with an absolute risk reduction of 2.2%. And this included variceal bleeding. On the topic of variceal bleeding, transfusion in suspected variceal bleeding is very tricky. I still think because we always recommend to avoid over-transfusion, which is obviously a difficult balance of cases of severe bleeding. There is some data that shows that increasing portal hypertension associated with over-transfusion can lead to worsening of the GI bleeding. In terms of monitoring, so you're resuscitating the patient, where do they need to go? So if they're actively bleeding, if you've seen blood, they should be at least in the IMC for telemetry and pulse ox monitoring with a better nursing ratio. For the interns, we generally recommend for active bleeders, hemoglobin, hematocrit, platelets, and INR be trended every 4 to 6 hours. For an inactive bleeder, a history of bleeding with nothing observed, you can probably get away with trending every 12 hours for a day, make sure there's nothing scary going on, and then you can switch to daily. The platelet goal with active bleeding is not based on any GI bleeding studies, just other hematological studies, but any active bleeding, or neurosurgery studies, but any active bleeder should have a goal for platelets greater than 50. As far as INR goals, and with cirrhotics, this is completely different because they can be prothrombotic or coagulopathic with a high INR. But with non-cirrhotics, where you can believe the INR, the goal is a little bit GI attending dependent for when we would feel that we can safely scope them, but a safe goal is 2. There is some recent data that shows that a goal, an INR in just the regular therapeutic for Coumadin range of less than 3 is probably safe for endoscopic intervention. But I would say, talk to the GI fellow first. That's always fine, and get a goal. We should put it in our notes. A risk assessment tool that you can use if you're in a clinic and you can get point of care hemoglobin, and you're debating whether or not to send the patient to the ER, or if you're evaluating a patient from the ER. I know you guys don't do the ER evaluation initially, but is the Blatchford Score. It's a pretty useful test. It's on most people's med calcs, and it predicts the need for endoscopic intervention before the EGD is performed, and that is to say, it predicts the need that they need to be inpatient for treatment. The score of greater than 0 is 100% sensitive for identifying a severe bleed. So if you have a score of 0, you can technically be managed potentially at home. I would err on the side of caution that you admit more patients that and grab some not severe bleeding than to err on the side of letting severe bleeders go home. But it may, like I said, it may allow for early discharge in 16 to 25% of all patients with upper GI bleeding and patients with a high risk. And I think this is something that you can use when you're stratifying patients as well for where they need to go and how urgent of a case of bleeding they are. Is their BUN greater than 25, a hemoglobin of less than 10, blood pressure less than 90, or a heart rate greater than 100. And then also comorbid CHF or cirrhosis. So we have resuscitation ongoing. We'll talk about medical management before the scope. So if you have a presumed upper GI bleed, Nexium 80 milligram bolus or a high dose PPI with 80 milligram bolus is always the initial medication. Oftentimes that's given in the ER. And then there's always a decision of the drip versus high-dose IV BID. 8 milligram per hour maintenance drip is perfectly fine, but so is Nexium 40 milligrams twice a day. It's been shown to be non-inferior and perfectly fine to use as long as you've gotten that initial 80 milligram bolus dose. With PPI management and upper GI bleed, there aren't a lot of hard outcomes that it improves in terms of mortality and rebleeding. There is no statistically significant difference in mortality, rebleeding, or progression to surgery. However, PPIs do downstage bleeding ulcer lesions and decrease the need for endoscopic intervention and prolonged hospital stay. So from a resource utilization standpoint, PPIs are a good thing. After treatment, there is data, I think it was a New England Journal of Medicine article many years ago that showed that after certain high-risk lesions or ulcer lesions are treated, 74 hours of high-dose PPI, it was a drip in the initial study, does improve mortality. And that's thought due to the increased prevalence of rebleeding at the 1 to 3 day mark post endoscopy as the highest risk. So a high-dose PPI after the procedures may also be recommended, and it's due to the mortality benefit. So variceal bleeding, again, if you suspect varices, you're going to be doing all that resuscitation stuff, and you're going to be calling us, and we're going to be getting a plan together quickly. So again, if you suspect that, if there's a history of cirrhosis or varices, and you treat with an octreotide 50 mics IV bolus followed by 50 micrograms per hour continuous IV infusion. And then the second, I think, important medication that you would start is ceftriaxone, or third-generation cephalosporin, 1 gram IV daily and the goal is for 5 to 7 days. And there was a prospective study that proved, or that in this prospective study, the thought was it prevents gut translocation of bacteria and improves mortality in cirrhotic patients with upper GI bleeding of any cause, regardless of variceal or other. So we recommend that immediately, and then you can always switch to a PO, Cipro, or a Bactrim to complete the course once they're taking the PO. For lower GI bleeding, medical management is more simple besides the resuscitation effort. The rule of thumb is if they're actively bleeding and have hematochezia, a colonoscopy is the likely plan unless they're hemodynamically unstable, in which case we'll be treating as an upper. So in addition to resuscitation, you want to give coli 4 liters PO. In general, the patient should be drinking 20 to 25 cc's every 15 to 20 minutes. And if they're not, you can consider an NG tube for PrEP if they'll allow it. And then also consider an NG tube placement if the patient is demented, altered, or unable to drink on their own. And again, you know, the decision to give coli can always be discussed with us because, you know, if a patient's had, we'll say, a very recent scope and they're having mild bleeding, we may elect just to observe them and see if they stop on their own. So it's always reasonable to touch base with us before giving coli. A few other considerations with lower GI bleeding. So if a patient presents with abdominal pain and hematochezia, it's important to not just focus on the hematochezia, but also on the abdominal pain, because that can change management in terms of do they need a scope or do they need something else, supportive care, antibiotics. Ischemic, infectious, and inflammatory colitis are all added to the differential if they have abdominal pain. So we always ask that a stat CT abdomen pelvis just with PO and IV contrast, not necessarily an angiography, be done for these etiologies to rule out colitis. You know, if you have a CT and you see colitis in the consistent with a clinical presentation of ischemic colitis, you know, we're not going to rush to scope them. There's no real utility from a hemostasis standpoint, but there would be a potential utility if you wanted to risk stratify them and see if their colon is, if they have some dead gut that might require surgery. So that would be the only reason we would scope those patients, and that's why a CT abdomen pelvis with abdominal pain and hematochezia is an important first step of workup. CT angiography, or I think it's called a GI bleed protocol order here. Those are generally reserved for patients in whom endoscopy is not feasible due to severe bleeding with hemodynamic instability. So in general, you're probably not going to order that without talking to us, because we still might want to treat those patients like an upper GI bleed, and we generally will by having a look from above first. If they're completely unstable, so they have a bleeding arterial lesion and we can't get them to scope, or they're definitely not going to be tolerating cholite after the initial upper endoscopy, that's when you consider a CT angiography. And then the angiography requires a blood loss of 0.5 to 1 cc's per minute for a bleeding site to be visualized, and that's a pretty brisk bleed. We don't get a ton of positive results. There is also a nuclear medicine test that you can order, the radionuclide study, which can predict, or which can be positive in slightly smaller, slower rates of bleeding. I think it's 0.25 to 0.5 cc's per minute of blood loss, but that's not going to help localize the bleed, and that's not going to be your first step. You'll probably talk to a GI fellow before ordering that. Anticoagulation management in active bleeding is there is data to help guide management, but there's not a ton of data to guide management. With vitamin K antagonists or warfarin, you always want to hold the medication in the setting of an active bleed if you can. And the goal INR, like I said, would be less than 2 or 3 in some cases, potentially maybe safe. To get to that goal, FFP is the immediate reversal agent, and then because FFP has a certain half-life of hours, you add vitamin K 5 to 10 milligrams IV for a long-term reversal that takes about 9 to 12 to 24 hours to reverse. In regards to direct-acting oral anticoagulants, like apixaban, edoxaban, and rivaroxaban, these are 10A inhibitors. Most mild to moderate bleeding, so they'll present, in the afternoon on a Wednesday, and you plan to, and they're not urgently bleeding with hypotension, and we don't need to scope them within that, that quick window once they're stabilized, and we have this 24-hour window. You can generally wait 1 to 2 days to allow for just spontaneous reversal, as the half-life is only 6 to 8 to 12 hours for most of these medicines. But if there's a severe bleed, we would consider a 3-factor prothrombin complex concentrate use plus FFP to make up for that 4th factor, or 4-factor PCC. I think from my experience here, it's 3-factor PCC is available at Metro Health. So that's something that you can consider using. Soon to be available, I think it was approved in June, is a reversal agent called, I don't know if I'm butchering it, but andexanet alpha. And that will be a medicine that can be delivered as a bolus followed by a 2-hour infusion. And there's either a low-dose bolus or a high-dose bolus. Those are going to be based on the how recent their last dose of anticoagulation was. So if it was more recent, you would give the high dose, and if it's, I can't remember the cutoff, but if it's more than 12 hours away or 24 hours away, you can give the low dose bolus. And this, again, allows for rapid reversal, and this should be coming if it's not already here. With antiplatelets, for severe or life-threatening bleeding, you want to hold the antiplatelet agent, generally like the clopidogrel or ticagrelor or like Valenta. For aspirin, for that, the decision to start, continue or not continue aspirin is sort of based on where the bleed is and how severe the bleed is. If it's an upper GI bleed, generally asked to hold it unless there's a very strong indication, because it can be associated with the presence of ulcers or the etiology that you're trying to stop. But if it's a lower GI bleed, so hematochezia without any instability, and the reason for the indication for the aspirin is secondary prophylaxis, you can generally continue the aspirin, and that's in our guidelines. But if it's for primary prevention of stroke or CAD, we would recommend to hold it then, because the indication isn't as strong. So anything other than a severe life-threatening bleed for antiplatelets, the decision really should be individualized based on indication. So it would be reasonable to consider cardiology or neurology consultation for complex decision-making with somebody with a recent stent, basically with somebody with a recent stent or recent stroke. In terms of when, we get this question a lot, when to resume anticoagulation and antiplatelet. There's really limited data to guide management post-bleeding. With warfarin, there is some data. There was one study, or a couple of studies, that looked at holding for a full 90 days after the bleed had stopped, and there was association with an increased risk of thrombosis and death. However, resuming within 7 to 30 days post-bleeding, so early resumption of Coumadin, led to a decreased risk of thrombosis and death. Again, there's limitations to this data. This was specifically a retrospective study, but based on the available data, it seems like early resumption of anticoagulation may be more beneficial. So that's generally what I think the goal should be, unless there's, and I'll talk about in a second here, unless there's some other reason not to. So in general, the risk of thrombosis outweighs the risk of recurrent bleeding. So the risk of a stroke with severe neurological deficits versus the risk of bleeding where it's potentially treatable and reversible. So it's generally best to resume medication just on that concept alone. You want to take into account the severity of the initial bleed presentation. So did they present with a hemoglobin of 4 and actively vomiting blood? Or did they just present with hemoglobin of 10 and had a couple episodes of bright blood per rectum? You're more likely to resume with the former. And then you want to take into account the risk of thromboembolism. So if the indication is a high-risk indication, so a history of blood clot, pulmonary embolism, CVA, or mitral valve replacement versus a low risk, so generally AFib unless their CHADS-2 VAS score is greater than 6. That's the next thing you want to take into account. And then you can consider a cardiology, hematology, or neurology input as well in making your decision, but ultimately I think the risk benefits should be discussed with the patient and a joint decision made that way. So I was asked to talk about timing your call to GI fellow. So I guess this is more for the interns. But we always recommend starting the appropriate medical management first, including the ABCs. So that's really the thing that will save their life. So that's the thing that takes precedence. So we want to know that you're actively resuscitating them. If in the ER or if you or your staff or the nurses have witnessed active bleeding, or you do a rectal exam and you see blood, that's another time that we should be called concurrently with resuscitation, because those patients are going to be more on the lines of once they're stable, we're gonna want to have a look, versus those that aren't actively bleeding, we're not going to come out in the middle of the night for that. So when to wait until the morning, or even as an outpatient. So if they have a history of bleed and the bleed is not observed in-house, if they have an FOBT positive stool or iron deficiency anemia, in which case you can consider outpatient evaluation unless they're receiving transfusions. Or then scan hematochezia. We get this question a lot with known hemorrhoids and a colonoscopy, within the last 1 to 5 years, they're up to date. You can just treat that symptomatically, and that would be with like stool softeners, Miralax, fiber in your diet, and then you can add anisole suppositories for 7 to 10 days total, and then have them follow up. But I just also want to add that if there's a question and you're concerned, you can definitely call us. I'm not saying don't call us, day or night. So in terms of timing of upper endoscopy, so the first line treatment after resuscitation and for diagnosis and therapy is upper endoscopy or EGD. This has a high sensitivity and specificity. It's the best test to start. For non-variceal bleeding, our goal time to endoscopy is 24 hours or less. Urgent upper endoscopy, or we get calls from the ER for life-saving EGDs immediately. That's very controversial. In non-variceal bleeding, actually, there are numerous studies that show that this may actually lead to worse outcomes probably due to under-resuscitation. So we like to make sure that they're stable. If you give them a dose of Versed, or you give the patient a stress with the scope down their throat when you can't sedate them enough due to their blood pressures not tolerating, can strain them, can cause NSTEMIs, can cause aspiration, it can cause a lot of bad things. So that's why we don't rush to scope these patients emergently. The caveat to that is variceal bleeding. So our goal time to endoscopy is basically as soon as they're stable. So they come in with a blood pressure in the 80s and they're tachycardic in the 120s. We give them a couple units and some fluid, and we get them 4 hours later to a reasonable blood pressure in the 100 systolic. That's really the best window to scope those patients. So we're going to be scoping them 2 a.m. whenever that they're stable, because those patients, you get that window. If you don't scope them in that window, they can rebleed or become unstable, and with the cirrhosis as limiting their overall reserve, those are the patients that we get really worried about and that can crump. In terms of lower GI bleeding, so the timing of colonoscopy, again, colonoscopy is the first line for lower GI bleeding. I would ask to generally identify high-risk features if I'm talking to somebody over the phone. So significant cardiovascular comorbidities, if they have persistent bleeding, blood on the exam. If they have an advanced age, I think that's technically an age over 60 for the purposes of the prior studies. Anticoagulation or antiplatelet use concurrently, anemia or elevated BUN. Those patients with multiple high-risk features should be scoped. Our recommendation is within 24 hours. The recommendation is never to scope somebody with who hasn't been adequately prepped because of such poor yield, lowering the benefit, and you get although it is a low-risk procedure, the risks of the procedure then become too risky if they're not compared to the benefits of the test. So we wouldn't do it unless they've had the prep. And but if they're low risk, those patients can generally wait for more than 24 hours if need be, or what have you. So a couple of pictures of lower GI bleeding. This is a bleeding diverticulum. I've seen, I'm a third year now, so I've seen 3 actively bleeding cases. But generally, these bleedings, these will stop. So they'll stop 70 to 85% of the time. Some people say that the colite, it may be what stops it. I don't know, but they all seem to stop. And this is, if they don't stop, what we do. So we'll clip at the neck of the diverticulum and stop the artery from bleeding. This is a colonic mass. It's a non-obstructive lesion, and these can ooze and are pretty common. And we may be able to do something about these now with the hemospray in terms of temporizing at least, although the hemospray does have a high rebleeding rate. So I think that's it from the slide perspective. I have a couple of vignettes I was hoping we could do. We have time? Okay. Does anybody want to do one? Otherwise, I'm going to call on people. Sorry, just right-clicked. It's coming up here. I wanted to do the presenter. All right. Okay. Yeah, exactly. So this is an active, probably upper GI bleed, and my point here was this patient's been resuscitated. They have their IVs in place. They're stable now. The next best step is to medically manage them with Nexium to downstage their potential lesion. Admitting to the floor is not the best step because they're actively bleeding, so they need to be monitored in a higher level of care. Colite, although they're coming in with hematochezia, they also have hemodynamic instability, so we would treat this as an upper GI bleed. And so colite, although they may be bleeding from a lower GI bleed source, we would not be looking there first. And then CT angiography, again, they were able to be resuscitated, so first line would be an upper endoscopy. Question 2.
28-year-old male with a history of IV drug use presents with acute abdominal pain, nausea, vomiting, and diarrhea. He taken bottle of streaks of blood 2 days ago. Last IV drug use 2 days ago is night NSAID use. On exam, his temperature is 99.5, heart rate is 96, BP 130 over 80, and respiratory rate is 12, chatting at 98% on the demand. Exam is notable for diffuse tenderness, but soft and non-distended. Rectal exam shows traces of blood of brown stool in the rectal bulb. The last WBC is 10.8. Hemoglobin is 11.7. Baseline is usually 11 to 12. Platelets 300. INR 1.2. ER calls you to admit the patient. They tell you he is not vomiting for survival 3 hours. What's the next step?
See? I think in general, when you're admitting somebody for bleeding, you want to, at least for the first 24 hours, have a look at their hemoglobin every 12 hours or so, and if it's stable, then you can go to daily. Yeah, so my point here was, although there is a report of hematemesis with small amounts, the patient's hemodynamically stable, their blood counts are actually at baseline, and there was nothing observed both on the rectal exam or witnessed in the ER. So I wouldn't call this an active bleed, I would call this an inactive bleed. They should be admitted, but the floor is probably reasonable for these patients with Nexium on board versus step down. And you should call the GI fellow, but this is probably, again, since it's a case that is non-urgent, would not be your next best step. Medical management would be your next best step.
Female with a history of multiple sclerosis was admitted 2 days ago for a UTI assessment. Sepsis resolved yesterday. She was given Toradol in the ER. Foreigners called after the patient developed nausea and bloody emesis for the past 1 hour. She is witnessed having about 1 liter of frankly bloody emesis. She now notes nausea and mild epigastric burning. On exam, temp 99 Fahrenheit, heart rate 105, BP 108 over 68, respiratory support is inside 95% on room air. The exam is notable for a woman appearing distressed with a soft, non-tender abdomen. She is oriented to placing current. She has hematochezia and cough. Special exam shows black tardy skin with left finger. She has 2 cysts hemoglobin 8.5, baseline 10.5 from yesterday, so it's 393, INR 0.9, B1, 87, and creatinine 0.6.
How long would you?
C and B at the same time? Yeah, I guess there could have been an E for C and B at the same time. Yeah, you would definitely be calling us. But yeah, I think that the point here is, you know, this patient's coughing, they're vomiting large amounts of blood, and so you're concerned about her airway, her breathing, her circulation, the ABCs first. So I think that intubating her for airway protection is probably the most important thing, with concurrent IV fluids for the, although she is still holding her pressure, she's a little tachycardic, so she needs volume, and then get her to the ICU. I would definitely call the GI fellow while doing all those things. But the best next step is to get that patient intubated. Obviously, a repeat CBC won't change your management at that time, because if they drop their pressures, you're going to give fluids or you're going to give blood if that's available. And it can take 12 to 24 hours for, you know, it's not going to be the next best step. And then obviously, keeping the patient on the floor doesn't sound like the best idea with an active bleeder. 2 more, I think. Who wants to do?
72-year-old female with a history of
Right.
diabetes, status, cabbage, hypertension, hyperlipidemia, hypothyroidism, type 2 diabetes, presents with a few episodes of bright red blood for rectum mixed with stool over the past 2 days, associated with cramping, left-sided abdominal pain, also for the past 2 days. Nice feverish chills, afebrile, heart rate 70, blood pressure 122 or 78, respiratory 12, saturated 97 on Vermeer. On exam, she was soft abdomen with left-sided tenderness and palpation. Rectal exam shows scant bright blood. Heart and lung exam is benign. WBC is 12. Hemoglobin 11.6. Baseline 11 to 12. So it's 290. B1 12. Creatinine 0.6.
D is correct. So this is the case I think I was talking about earlier with abdominal pain plus hematochezia. So you'd want to do a CT scan to rule out or to evaluate for ischemic colitis, especially in somebody with multiple cardiovascular risk factors, CAD, hypertension, diabetes, hyperlipidemia. In a person over the age of 60, this clinically looks like ischemic colitis until proven otherwise. FOBT, probably not going to change your management. GI consult, yes, you would probably do that too, but I think the CT would be more important. But if you wanted to call us and ask if we should do a CT, that would be fine too. And then C, transfusing 1 unit. We talked about the restricted transfusion strategy of 7, but with somebody with potentially significant cardiovascular risk factors, I guess there could be an argument to do 9, but either way, she's sitting there at 11, so I wouldn't transfuse her. And she's not tachycardic and has a normal tensive. And surgery, so sometimes if the patient has a significantly, severe abdominal exam with guarding or rebound guarding or something to suggest peritonitis, you would consider that, but in this case, I don't think it's severe enough to just call them immediately. Last one.
40-year-old male with a history of decompensated cirrhosis with ascites, prior esophageal varices, and hepatic encephalopathy presents with hemocentris and confusion for the past 12 hours. He was with an episode in the ER, 10.8.3, heart rate 125, BP 80 or 40, respiratory 12, saturated 98 on Vermeer. He's oriented himself only in method non-tender absence. 216-gauge IVs are placed in the 2 liters normal saline in the ER. WBC 6, hemoglobin 6.2, platelet 70, INR 1.6.
Yeah, the longest answer. Yeah, so this is the thing that we get very concerned about. This is how a variceal bleed presents, not with FOBT positive stool. They're actively bleeding overtly. They're hypotensive. They're tachycardic. and they have a history of decompensated cirrhosis or even just compensated cirrhosis presenting for the first time. This is what these patients will look like. You would want to intubate these patients for airway protection, start octreotide, get blood to get that hemoglobin up without over-transfusing. The point of B was, yeah, you might want to give them blood immediately, but 10 units in somebody with cirrhosis can worsen their portal hypertension and potentially worsen the bleeding. So less than 10 units or less than a massive transfusion protocol. Q6 hours CBC, so you do want to trend active bleeders every 4 to 6 hours, so that'd be reasonable, but it's not the next best step. And then just calling GI and saying, help me, probably is not going to help patient survive. So I think that's it. Do you have any questions? Okay. Thank you. Good.